Gastrointestinal bleeding. Upper and lower GI bleed arise from two general groups of etiologies. Etiology of gastrointestinal bleeding. Location upper, lower. Most common cause upper is ulcer disease and lower GI bleeding is diverticulosis. Other causes upper GI bleeding, esophagitis, gastritis, cancer, duodenitis, and varices. Lower GI bleeding, angiodysplasia, polyps, IBDs, cancer, upper GI bleeding, and hemorrhoids. These MCQ, a 69-year-old woman comes to the emergency department with multiple red black stools over the last day. Her medical history is insignificant for aortic stenosis. Her pulse is 115 per minute and blood pressure is 94 by 62 mm mercury. This examination is otherwise normal. What is the most appropriate next step in management? The bolus of normal saline. Because she is going to shock 94 by 52 is her blood pressure and the pulse is 115 per minute. Even if she has GI bleeding, she is going to shock. So first you must give him normal saline. 5. Answer D. Identifying the etiology of severe GI bleeding is not as important as giving fluid resuscitation. There is no point in checking for orthostasis when the patient's systolic blood pressure is less than 100 mm mercury or when there is a tachycardia test. Endoscopy should be performed, but not as a first step. When BP is low, normal saline or liquid lactate are better. Fluid to give than 5% dextrose in water. Dextrose in water does not stay in the vascular space to raise BP as well as normal saline. Now, assessing BP is the most important initial management of GI bleed. Ischemic colitis. Older patients with history of diabetes mellitus, hypertension, and vascular disease are susceptible to ischemic colitis. If present with left lower quadrant pain, mucosal friability on scope, and a clear demarcation between ischemic and normal tissue is spares rectum. Now, the condition is not life-threatening and bleeding resolved without specific treatment. Physical symptoms include orthostasis, greater than 10-point rise in pulse when going from lying down to sitting or standing, or greater than equal to 20% drop in systolic blood pressure when sitting up. Variceal bleeding, only form of GI bleed in which physical examination helps determine etiology. The presence of the signs of liver disease helps establish the diagnosis. Suspect variceal bleed when symptoms including vomiting, blood plus or minus black stool, spire angiomata and caput medusa, splenomegaly, pulmonary erythema, or asterixis. Now, initial management of GI bleeding is not based on the etiology, it is based on the severity. The acute bleeding, especially when severe, is far more common, important to replace fluids, check the hematocrit, platelets, and run covalent tests such as PT or INR than it is to do an endoscopy. Severity of blood loss based on hemodynamics. Physical finding, percentage of blood loss. Orthostasis, 15 to 20% blood loss. Pulse greater than 100 per minute, 30% blood loss. Systolic BP less than 100 mm mercury, 30% blood loss. Pulse greater than 100 per minute and systolic BP less than 100, 30% blood loss. Orthostasis, 15 to 20% blood loss. Diagnostic testing is with the nasogastric tube, but this has a limited benefit. There is no treatment to be delivered through the NG tube, but it can guide where to start endoscopy. If upper endoscopy will be done anyway, NG tube has limited role. About 10% of those with red blood from the rectum have high volume upper GI bleeding with rapid transit time. The sensitivity of the NG tube is 90%. If you see bias in this aspirate, however, then you know the NG tube aspirate really is greater than 95% sensitive. If the stool is black and a person with cirrhosis but there are no hematemesis, an NG tube showing red blood may tell you to use octreotide for varices and run urgent endoscopy for possible banding of varices. Now, 80% of GI bleeding will stop spontaneously if the fluid resuscitation is adequate. Most patients die of inadequate fluid replacement. Additional diagnostic testing for GI bleeding. Test indication. Nuclear bleeding scan. It is indicated in endoscopy revealing a massive acute hemorrhage and lacks accuracy. Angiography. Specific vessels or site of bleeding needs to be identified prior to surgery or embolization of the vessel used only in massive non-responsive bleeding. Capsule endoscopy is done in small bowel bleeding. Upper and lower endoscopy do not show the etiology. Theater of the abdomen do not include in GI bleeding. EKG lactate level it shows ischemia and severe bleeding. Treatment of GI bleeding is as follows. Treatment of GI bleeding is as follows. Fluid replacement, packed red blood cells, fresh foreign plasma, platelets, reversal of anticoagulants, endoscopy to determine diagnosis, and IV PPI for upper GI bleeding, and surgery. Fluid replacement with high volumes, 1 to 2 liters per hour of saline or liquid lactate in those with acute severe bleeding. Packed red blood cells. If hematocrit is less than 30, a patient older or suffers from coronary artery disease, a patient is young, transfusion may not be needed until the hematocrit is very low, less than 20 to 25. Peripheral plasma, the PTR INR is elevated and active bleeding is occurring. Platelets at less than 50,000 and there is bleeding. Reversal of anticoagulants, adenanet, adexanet, alpha reverses 10A inhibitors, rivaroxaban, apixaban, and endoxaban. Idarucizumab reverses dabigatran, and prothrombin complex concentrate reverses warfarin. Endoscopy determines the diagnosis and administers some treatment. Pancreatitis, corticoid ulcers, inject epinephrine into bleeding gastric vessel. Intravenous PPI for upper GI bleeding. Surgery to remove the site of bleeding of fluids. Blood, platelet, and plasma will not control bleeding. Tip: platelets are transfused when count is less than 50,000 per microliter and there is active bleeding. You would not transfuse platelets to prevent a spontaneous bleed unless the count was much lower, less than 10,000 to 20,000. Esophageal and gastric varices. What do you do in addition to administering fluid, blood, platelets, and plasma? Octreotide, it is somatostatin, decrease portal pressure. Banding, perform endoscopy of the trays of esophageal varices. Transrectal intrahepatic portosystemic shunts is used to decrease the portal pressure in those who are not controlled by octreotide and banding. Propranolol or lanolol is used to prevent subsequent episodes of bleeding. Beta blockers such as propranolol will not do anything for the current episode of bleeding. Antibiotic to prevent spontaneous bacterial peritonitis if a site is present. Blackmore tube or balloon tamponade is rarely used as a temporary measure before the procedure. Surgery therapy, never the right answer if banding is technically possible for esophageal and gastric varices. Diarrhea. Antibiotic-associated diarrhea. Although clindamycin may be associated with the highest incidence of antibiotic-associated diarrhea and Clostridium difficile, any antibiotic can potentially cause diarrhea. Blood and white blood cells may be present in the stool. It usually presents several days or weeks after the start of antibiotics. Best initial test is a stool Clostridium difficile toxin test. The most accurate test is a PCR or NAAT. Treatment is oral vancomycin, most effective nasal therapy. If there is no response, switch to pyridoxomicin. For a patient with positive Clostridium difficile stool toxin but no symptoms, there is no treatment needed. Now the scenario, a 75-year-old man is admitted to the hospital with pneumonia. Several days after the start of antibiotics, he begins to have diarrhea. The stool Clostridium difficile toxin is positive and he is started on vancomycin. He resolves the diarrhea after a few days. 2 weeks later, the diarrhea recurs and the Clostridium difficile toxin is again positive. What is the most appropriate next step in management? Retreat with vancomycin. Recurrent episode of Clostridium difficile associated diarrhea are best treated with another course of vancomycin. Intravenous metronidazole is used only if oral therapy cannot be used, such as in a patient with an aerodynamic ileus. Stool is never cultured for Clostridium difficile because it simply will not go in culture. Endoscopy looking for stool membranes will diagnose antibiotic-associated diarrhea, but is not necessary step given the availability of stool toxin assay. Now, intravenous vancomycin is always wrong for antibiotic-associated diarrhea since it will not pass the bowel wall. And now, memorize this. What is fulminant Clostridium difficile? It is high WBC greater than 15,000, metabolic acidosis, high lactate, high creatinine, 1.5 multiplied baseline. Fulminant Clostridium difficile is high WBC greater than 15,000, metabolic acidosis, high lactate, high creatinine. Now, several conditions come to play in the treatment of Clostridium difficile. Both vancomycin preferred and pyridoxomicin have better efficacy than metronidazole. Vancomycin is less expensive than pyridoxomicin. If vancomycin is preferred but cannot be given orally, it can be given by enema. If there is recurrence after vancomycin, give a tapered dose of vancomycin or pyridoxomicin. After multiple recurrences, use pegloticizumab or do fecal transplantation. Pegloticizumab is an antibody against Clostridium difficile toxin. For fulminant life-threatening infection, use vancomycin plus metronidazole. Tip: switching to pyridoxomicin is the answer when the case does not respond to vancomycin. Now memorize this. Figure 1.9 antibiotic-associated diarrhea algorithm. Diarrhea after antibiotic use, yes. Clostridium difficile positive? No, then consider alternative causes. If yes, then treat with vancomycin. If there is improvement, then continue vancomycin until end of course. If no improvement, then switch to pre-doxomycin. Malabsorption. Celiac disease is one of the most common types of malabsorption can be present as an adult. Chronic pancreatitis has a very similar presentation with fat malabsorption. Rare cause of fat malabsorption are tropical screw and Whipple disease. All of these present with steatorrhea, defined as a stool that is oily, greasy, floating, and foul-smelling. Now, all forms of fat malabsorption present with a deficiency of fat-soluble vitamins, such as vitamin A, D, E, and K, hence they all can present with the following. Deficiencies and manifestation. Deficiency manifestation. Vitamin D, hypercalcemia, osteoporosis. Vitamin K, bleeding, easy bruising. Vitamin B12, anemia, hypercyclemia, neutrophils, and neuropathy. Now, tip. Fat malabsorption frequently presents with weight loss. Celiac disease is associated with thyroiditis, vitiligo, pernicious anemia, and type 1 diabetes. When vitamin B12 needs an intact bowel wall and pancreatic enzymes to be absorbed. Presentation. There is nothing clinically to distinguish tropical screw from celiac disease, gluten, sensitive enteropathy. People disease also present with arthralgias, ocular findings, neurological abnormalities, dementia, seizures, fever, lymphadenopathy, with ceftriaxone followed by TMP-HMZ-X. Celiac disease gives dermatitis hermatiformis in 10% of cases. Now, diagnostic test. One of the most important main distinctions between chronic pancreatitis and gluten sensitivity enteropathy is the presence of iron deficiency. This is because iron needs an intact bowel wall to be absorbed but does not need pancreatic enzymes to be absorbed. Unique tests for celiac disease are anti-tissue transglutaminase (TTT). The first test can be falsely negative in IgA deficiency, anti-endomycin antibody, IgA antigliadin antibody. The most accurate diagnostic test for celiac disease is a small bowel biopsy that shows flattening of the villi. Whipple disease and tropical screw are also most accurately diagnosed with a bowel wall biopsy during the specific organism. Red and rice and wine are safe in celiac disease. Bowel biopsy is essential in celiac disease to exclude lymphoma. Techno. Chronic pancreatitis. Diagnostic testing includes abdominal X-ray, 50 to 60% sensitive for calcification of the pancreas, abdominal CT, 8 to 9% sensitive for pancreatic calcification, MRCP or EUS, with secretin enhancement is more accurate than CT scan. Secretin stimulation test, more accurate test. Placed in nasogastric tube. Administer an IV injection of secretin. A normal pancreas will release a large volume of bicarbonate-rich fluids. This secretin stimulation test. Now, the abdominal X-ray is very specific for chronic pancreatitis when the test is abnormal. The angiotensin receptor blockers or olmesartan gives a sprue-like illness. Figure 1.10 chronic pancreatitis leads to calcification of the pancreas, visible in X-ray in 50 to 60% of patients. See here, chronic pancreatitis. Figure 1.11 abdominal CT scan has greater sensitivity and specificity in the detection of calcification of the pancreas. Here is calcification of the pancreas, pseudocyst. Treatment. Disease-specific treatment. Chronic pancreatitis, enzyme replacement. Celiac disease, avoid gluten-containing foods, such as wheat, oats, rye, or barley. Whipple disease, ceftriaxone, thiametoprim, or sulfamethoxazole. Tropical fruit, trimethoprim, sulfamethoxazole, doxycycline. The D-xylose test is an old test that distinguished pancreatitis from bowel wall abnormalities. D-xylose test results are normal in pancreatic disorder. Now, Carcinoid syndrome. Carcinoid syndrome presents with intermittent diarrhea and associated with flushing, wheezing, cardiac abnormalities of the right side of the heart. The best initial diagnosis test is the urinary 5-hydroxyindole acetic acid 5-HIA test. Treatment of octreotide, a synthetic version of the somatostatin, to control the diarrhea.